396. The thyroid gland is responsible for the production of thyroid hormone and calcitonin. Calcitonin is secreted by the perifollicular cells and is involved in calcium homeostasis. Thyroid hormone is critical in regulating body metabolism. Underline that. So your thyroid hormones or metabolism, neurologic development, and numerous other body functions. Clinically, conditions affecting thyroid hormone levels are much more common than those affecting calcitonin, and this is the major focus we're going to talk about in this chapter. So thyroid anatomy and development. The thyroid gland is positioned in your lower anterior neck, and it is shaped like a butterfly. It is made up of two lobes resting on each side of the trachea, bridged by the isthmus with a band of thyroid tissue running anterior to the trachea. Posterior to the thyroid gland is the parathyroid gland, and that regulates serum calcium levels. Underline that, you need to know that. Your parathyroid hormones regulate serum calcium levels. Go to the next paragraph, 4 lines down. By week 11 of gestation, the thyroid gland begins to produce measurable amounts of thyroid hormone. Underline this. Iodine is an essential component of thyroid hormone. Iodine. I did not believe this whenever this person told me this until I tried it myself. So it was a girl that I actually worked with at Swainsboro at Tech. She used to work for a chiropractor. And, you know, they're all about like holistic medicine and stuff like that. And so I had a sore throat one time because my sinuses were draining. So it caused me to have a sore throat. She said, go over there to get some iodine and put some iodine on your wrist. And I was like, okay, how's that going to help my sore throat? But it did because of my thyroid. And so if you need iodine, like if your thyroid needs iodine, if you put it on your wrist right there, you'll absorb it and it'll literally, it almost makes your throat go numb, kind of. It was pretty cool. So if you ever have a sore throat, put some iodine on your wrist. It'll help. In parts of the world where severe iodine deficiency exists, neither the mother nor the fetus can produce adequate amounts of thyroid hormone, and both develop hypothyroidism. As thyroid hormone is critical to fetal neurologic development, neonatal hypothyroidism can lead to mental impairment. In areas where iodine deficiency is not an issue, other problems with thyroid development may occur. And speaking of like thyroid hormones, whenever the baby is born, as part of the neonatal testing, the PKU, they also check your TSH levels and your, I want to say 3 to 4 levels, which are thyroid hormones, to check and make sure that the baby has adequate thyroid hormones, because if not, then it can lead to mental disability. So go down to thyroid hormone synthesis. Thyroid hormone is made primarily of the trace element iodine, making iodine metabolism a key determinant in thyroid function. Iodine is found in seafood, dairy products, and vitamins. Interestingly, iodine is used in high concentrations in the contrast medium used in many radiologic procedures, like a CT scan or a heart cath. Go down to the next paragraph. Thyrocytes, which are thyroid cells, are organized into spheres surrounding a central core of fluid called colloid. These structures are called follicles. The major component of colloid, which is thyroglobulin, is a component manufactured exclusively by thyroid follicular cells. Go up where you see TPO, thyroid peroxidase. You need to know what TPO stands for. It stands for thyroid peroxidase. And it's just an enzyme that your thyroid secretes. T3 and T4 we're going to talk about in a minute, the triiodothyronine and thyroxine. We're going to talk about those. Go to thyroid stimulating hormone, TSH. You need to know what that means also. It is released from the anterior pituitary, and it signals the follicular cell to ingest a droplet of colloid by endocytosis. Inside the follicular cell, these droplets are digested by lysosomes into T4, T3, and other products. Then T4 and T3 are secreted by the follicular cells into the circulation. So turn the page. Control of thyroid function. Go down to 4 lines where it says TRH. Under control of thyroid function. So 4 lines down, TRH. TRH is thyrotropin releasing hormone. And if you want to look back like directly across from it, it's down there, what it means. Thyrotropin releasing hormone. It is synthesized by neurons in the supraoptic and supraventricular nuclei of the hypothalamus and stored in the median eminence of the hypothalamus. So out beside that, right, number 1, your notes or whatever. The hypothalamus secretes TRH. When secreted, this hormone, so it's talking about TRH, when the hypothalamus secretes TRH, this hormone stimulates cells in the anterior pituitary gland to manufacture and release TSH. So your second is your anterior pituitary. I'm gonna like the off this. So you have TRH, which is thyrotropin releasing hormone. The hypothalamus secretes it. Then your anterior pituitary senses that TRH was secreted, and it produces and secretes thyroid stimulating hormone. Well, just by the name of it, what do you think the thyroid stimulating hormone does? Stimulates the hormones of the thyroid, right? Okay. So it says, then in turn, it circulates to the thyroid gland and leads to increased production and release of thyroid hormones. So then step 3, your thyroid thyroid hormones, which is T4 and T3. That's essentially how it works. When the hypothalamus and pituitary sense that an inadequate amount of thyroid hormone is in circulation, the TRH and TSH secretions will increase, so it will stimulate increased thyroid hormone production. If thyroid hormone levels are then high, then TRH and TSH release will be inhibited, leading to lower levels of thyroid hormone production. Go to actions of thyroid hormones. Once released from the thyroid gland, thyroid hormones, so T4 and T3, circulate in the bloodstream either bound to protein or as a free active hormone. Free T4 and free T3 circulate unbound. It's the name, free T4 and free T3. They are not bound. So they're able to bind to cellular membrane transporters and move across the cell membrane. Go all the way down to where you see thyroxetosis and go up 3 lines where it says clinically individuals. Clinically, individuals who have excess thyroid hormone production, which is called hyperthyroidism, or either increased circulation of the thyroid hormone from any cause, that's called thyrotoxicosis, will have symptoms of increased metabolic activity, such as tachycardia and tremor. In contrast, individuals with hypothyroidism, so decreased levels, note symptoms of lowered metabolic activity, such as edema and constipation. So usually if you have hyperthyroidism, you have like weight loss and stuff like that because your metabolic response is high. However, if you have hypo, you might have weight gain because your metabolic response is low. Go to test for thyroid function. So your thyroid stimulating hormone, TSH. But I start by this. The most useful test for assessing thyroid function is the TSH. So over anything else, over your T3, T4, free T3, free T4, your TSH can tell you the most about your thyroid. Okay? Turn the page to thyroxine, which is T4. Serum total T4 levels are usually measured by chemoluminetric assay or similar immunometric technique. Because more than 99.9% of thyroid hormone is protein bound, alteration in thyroid hormone level binding proteins frequently leads to total T4 levels outside of the normal range without representing true clinical thyroid dysfunction. Because of this, assays to measure free T4 and free T3, which are the biologically active hormone forms, were developed. Make a note. Well, it kind of says it down here. So go to T3. Iodothyronine. The thyroid gland produces only approximately 20% of T3, which contains 3 atoms of iodine. The other 80% of the total T3 is derived from the deionization or conversion of T4 to T3. So underline conversion of T4 to T3. So T4 converts to T3. Make sure you know that. So quantitatively, there's more circulating T4 than T3 levels in the blood, but T3 is the most biologically active thyroid hormone. Go to free T4. Free thyroxine, which is free T4, compromises a small fraction of total thyroxine because T4 is bound to thyroid carrier proteins. Free T4 is available to enter the tissues and therefore is biologically active fraction of T4. Clinically, it is used as a second line test after TSH. So TSH and free T4 levels are your main two. In the evaluation of suspected thyroid disorders, and when used in conjunction with TSH, allows for a more accurate diagnosis of thyroid function. As you didn't you say your mama had thyroid labs that are abnormal? Go down to the last minute. Known interfering substances include thyroid autoantibodies, biotin, and human anti-mouse antibodies. So biotin does that. I want you to write, it's not in your book, but out to the side, it's called an FTI index calculation, which is free thyroxine index. So this is your index. Wait for time. I think it's time. Yeah. T4 times your T3 divided by 100. FTI, free thyroxine index. T3 times T4 divided by 100. On to the next page. Thyroglobulin. Thyroglobulin is a protein synthesized and secreted exclusively by thyroid follicular cells. This prohormone in the circulation is proof of the presence of thyroid tissue. This fact makes thyroglobulin an ideal tumor marker for thyroid cancer. So highlight that and start out. Thyroglobulin, tumor marker for thyroid cancer. Patients treated with thyroid cancer successfully are treated with surgery or radioactive iodine ablation and should have undetectable thyroglobulin levels. Go to the next paragraph and go down 4 lines. The accuracy of the thyroglobulin assay is primarily dependent on the specificity of the antibody used and the absence of antithyroglobulin antibodies. Even with modern assays, antithyroglobulin autoantibodies interfere with measurements and lead to unreliable thyroglobulin results. For this reason, it's critically important for or to screen for autoantibodies whenever thyroglobulin is measured. So go to thyroid autoimmunity. Many diseases of the thyroid gland are related to autoimmune processes. If autoimmune thyroid disease, antibodies are directed at thyroid tissue with variable responses. The most common cause of hyperthyroidism is Graves' disease. So Graves' disease, hyperthyroidism. Graves' disease is an autoimmune disorder and it will cause hyperthyroidism. Yeah. You're not measuring eyeball. Go down to Hashimoto's thyroiditis. It is at the other end of the autoimmune continuum. In this condition, antibodies lead to decreased thyroid hormone production. So it is the most common cause of hypothyroidism. So Hashimoto's, hypothyroidism. Turn the page. Go to thyroperoxidase antibody. So thyroperoxidase, which is TPO, you need to know what that stands for, is an enzyme found in the thyroid gland that is involved in thyroid hormone synthesis. The TPO is thyroperoxidase. So there are other tools for thyroid evaluation. First, they're going to do blood work because that's the most invasive and it's the cheapest to do. When your blood work comes back abnormal, then they're going to do this stuff right here. So a nuclear medicine evaluation. Radioactive iodine is useful in assessing the metabolic activity of thyroid tissue and assisting in the evaluation and treatment of thyroid cancer. Go down. Well, really, let's just repeat myself. Go to thyroid ultrasound. That's another one. And it's just an ultrasound of your thyroid. And the next one is fine needle aspiration. 7-line sound where it says in this procedure. In this procedure, a small gauge needle is inserted into the thyroid nodule and cells are aspirated for cytology evaluation in the laboratory. So now go to disorders of the thyroid. Hypothyroidism. Hypothyroidism is defined as low free T4 levels with a normal or high TSH. Make sure you know that. Low free T4, normal or high TSH. So we know that T4 and T3 are your true thyroid hormones, right? So those is what's going to say whether it's hypo or hyper. Okay, so if your free T4 is low, it's some type of hypo, but then your TSH would be high because what's your TSH doing? Yeah, trying to balance this, trying to stimulate your thyroid to create more thyroid hormones, right? Okay, so low free T4, high TSH. Go down to the very last sentence. When thyroid hormone is significantly decreased, symptoms of cold intolerance, fatigue, dry skin, constipation, hoarseness, dyspnea on exertion, cognitive dysfunction, hair loss, and weight gain have been reported. So remember, your metabolism sucks at this point, okay? Because you don't, what are your thyroid hormones? What are they supposed to do? Metabolism, right? Well, if you have low hormones, that means they're not working, okay? On physical examination, those with severe hypothyroidism may have low body temperature, bradycardia, delay in the relaxation phase of deep tendon reflexes, yellow discoloration of the skin, hair loss, diastolic hypertension, pleural and pericardial effusions, menstrual irregularities, and edema. Go Jump not to the next paragraph, but the next, where it says hypothyroidism can be. Hypothyroidism can be divided into primary, secondary, or tertiary disease, depending on the location of the defect. The most common cause of hypothyroidism is Hashimoto's thyroiditis, which is the autoimmune disorder. This disorder is an autoimmune disease targeting the thyroid gland, often associated with an enlarged gland or goiter. Has anybody ever heard of a goiter? It's where they have like where a guy's Adam apple is, which is where your thyroid is. It comes out because your thyroid is enlarged, so it like pops out. You just like you have a really big Adam apple, but bigger, a lot bigger. Go to treatment on the next page, put a star by this. Hypothyroidism is treated with thyroid hormone replacement therapy. So levothyroxine, which is T4, is the treatment of choice. Put a star by that. Because obviously, what do our labs look like? What do we have low of in hypothyroidism? We have low what? T4. So what are we going to treat them with? T4. Makes sense, right? So go to thyrotoxicosis. Go down 3 lines. Thyrotoxicosis, or 4 lines, sorry, can be the result of excessive thyroid hormone ingestion, leakage of stored thyroid hormone from storage, or excessive thyroid gland production of thyroid hormone. The manifestations of thyrotoxicosis vary depending on the degree of thyroid hormone elevation and the status of affected individuals. Symptoms include anxiety, emotional lability, weakness, tremor, palpitations, heat intolerance, increased perspirations, weight loss, despite a normal appetite. Hyperthyroidism. So thyrotoxicosis and hypothyroidism, they're pretty much the same thing, okay? Graves' disease is the most common cause of hyperthyroidism. So hypothyroidism and Hashimoto's, your T4 will be what? Decrease, and your TSH will be increased. With hyperthyroidism or thyrotoxicosis or Graves' disease, your TSH will be what? Decreased, and your free T4 and T3 will be increased. The opposite. Y'all understand? Turn the page. The next paragraph. Thyroid disease associated with Graves' disease is treated with medication, radioactive iodine surgery, or a combination of both. Put a star by that. So that's how you treat hypothyroidism with Graves' disease, is medication, radioactive iodine, surgery, or a combination of them. Hypo. Oh, hyper, I'm sorry. Yes. The next paragraph, when radioactive iodine or surgery is used, the goal is to destroy or remove enough thyroid tissue so that the patient becomes hypothyroid. And then if they become hypothyroid, then you can treat them with what? Which is better than surgery, right? Or radioactive iodine, okay? So go to the next page. Toxic adenomas and multinodular goiters are two common causes of hyperthyroidism. You can just read about the other stuff. That's it. Not bad. Any questions about the chapter? And now we're done with chemistry. Test will be Monday. Thursday.